While it was a pandemic, I will focus on the 1918 influenza and its impact on the United States. The geographic point of origin of the 1918 virus strain is still unknown, but the earliest recorded outbreak was among Army recruits at Camp Funston, Kansas, which is present-day Fort Riley. The Spanish flu is a misnomer. Spain was a neutral country during World War I. There was no wartime censorship of their news, so they were the first country to publicly report on the pandemic. Just to reiterate, this pandemic did not start in Spain. Infections happen in 3 rapidly successive waves within a 9-month period. In the US alone, there were about 675,000 deaths due to the 1918 influenza. What is interesting is that this influenza strain affected young adults between the ages of 20 to 40 years old the hardest, compared with less than 0.1% mortality rate in other influenza epidemics. The mortality rate was more than 2.5% in 1918. The world was at war when the 1918 influenza broke out. Countries were training men and mobilizing their militaries transnationally. As previously stated, the first recorded outbreak was at Camp Funston in March of 1918. From there, the influenza was taken abroad by way of American troop ships. Because of these massive movements, it is believed to have facilitated the pandemic. The first wave is associated with high morbidity but low mortality rates, not too unusual for influenza. Possible mutation occurred in the summer, and we see its devastating effects in the subsequent, more fatal second and third waves. The second wave occurred in the late summer, early fall. In late August, it was reported that troops sick with influenza were returning to and stationed at the Boston Commonwealth Pier in Boston, Massachusetts, and from there it spread westward. Crowding, migration, poor ventilation, and sanitation found on the battlefield and encampments amplified the transmission of this infectious disease. Philadelphia sees the highest mortality rate in the nation. On September 28, 1918, Philadelphia held a parade where some 200,000 people descended upon its streets to participate. 2 days after the parade, the city's public health director, Wilmer Cruson, issued a grim pronouncement. The epidemic is now present in the civilian population and is assuming the type found in naval stations and army camps. 3 days after the parade, every bed in Philadelphia's 31 hospitals was filled. The third wave follows in the winter of 1918 and continued well into 1920 before the virus loses its virulent steam and becomes a seasonal virus. What did cities do? The sick were quarantined to contain the spread of infection to a healthy population. Like what we are seeing today with the COVID-19 pandemic, cities essentially shut down. The first line of defense is public health intervention. Schools, churches, restaurants, and public areas were closed. Shelter-in-place orders went into effect, and people were required to wear a mask when they went out in public. New York City, which reacted earliest to the crisis with mandatory quarantines and staggered business hours to lessen the amount of people out in the streets, experienced the lowest death rate on the eastern seaboard. Proceedings of the National Academy of Sciences sought to understand how responses influence the disease's spread in different cities. By comparing fatality rates, timing, and public health interventions, they found death rates were around 50% lower in cities that implemented preventative measures early on, versus those that did so late or not at all. What do we know? Much is still unknown about the 1918 influenza strain. What researchers have deduced through gene sequencing is this strain is the common ancestor to the H1N1 influenza virus we see today. Because of this, pigs are believed to be the intermediary between humans and avian virus strains. Majority of deaths were due to secondary bacterial pneumonia as antibiotics were unavailable at the time. However, there was a subset of people that died rapidly after onset of symptoms. often with massive acute pulmonary hemorrhage or pulmonary edema, often in less than 5 days. Gathered from autopsies performed in 1918, primary pathologic findings found infections were confined to the respiratory tree, hence death due to pneumonia and respiratory failure. Why this particular age group suffered the most is still not fully understood. Then versus now. Because of what we know now, healthcare providers take the flu seriously. Our public health system is more advanced today. We understand influenza better, and because of this understanding, we have knowledge in regards to prevention. We have an established prevention program which include annual vaccinations with up-to-date influenza and pneumococcal vaccines. We also have antibiotics to treat pneumonias caused by Streptococcus pneumoniae and Streptococcus pyogenes, identified as the bacterium linked to the secondary bacterial infection in 1918 influenza patients. Hospitals today have intensive care units and supportive therapy, such as ventilatory support, for those patients that experience severe respiratory distress. We also have biomedical research capabilities where researchers are constantly learning about the influenza virus and developing new vaccines for each new strain. In summary, a lot is still unknown about the 1918 influenza strain. 3 rapidly successive waves happened within a 9-month period. World War I helped spread the influenza virus. Early public health intervention was key to containment and low mortality rates. The affected age range were young adults between the ages of 20 and 40 years old. Advancement in medicine and research has provided us with influenza and pneumococcal vaccines and antibiotics. This proves public health needs to be funded. We need to be proactive rather than reactive.